can start, sir.
Okay, I'd like to start with the permission of chair. Now, session 4, named Korotoa, session topic pericardial and myocardial diseases. Good afternoon, everybody from BD Eco Virtual Conference 2020. We have got chairpersons here, 4 eminent speakers from abroad, international faculty. Now, I'd like to mention our honorable chairpersons. First, Honorable Professor Sajal Krishna Banerjee, ex-chairman, cardiology, BSMU, and Dean Medicine Faculty, Bangabandhu Sheikh Mujib Medical University. And Professor M. Syed Mostafa Kamal, Professor of Cardiology and ex-head of the department, Chittagong Medical College. Professor Nazir Ahmed, National Heart Foundation, Dhaka. Professor Mohammad Safiuddin, Professor of Cardiology, BSMU. Professor M. Shahabuddin, Head of the Department, Sylhet M.A.G. Osmani Medical College. Professor S.K.A. Razzaque, Consultant of Cardiology, Anwar Khan Medical College. Professor Probir Kumar Das, Head of the Department, Cardiology, Chittagong Medical College. Dr. Rakesh Gupta, sir, Senior Consultant Cardiology, Max Super Specialty Hospital, and also pioneer and chief consultant of Shrivastava Institute. Dr. Shomir Shrivastava, director and head of non-invasive cardiology Fortis Escort Heart Institute, New Delhi, India. And Dr. Avhijit Chatterjee, consultant cardiology, Rabindranath Tagore International Institute of Cardiac Science, Kolkata. Now, I'd like to request Dr. Masuma Jannat, please mention the panelist. Unmute. You are not audible.
Madam, you are not audible.
Okay, I'd like to mention here panelists. We have got respected panelist Professor Nazir Ahmed Chowdhury, retired Professor, National Institute of Cardiovascular Disease. She also freedom fighter. Professor A.B.M. Abdul Salam, retired Professor and Head of the Department Pediatric Cardiology, NICBD. Professor Syed Nasiruddin, Professor of Cardiology, NICBD. Professor Manjur Mahmood, BSMU, and Dr. Mohammad Raisuddin Mondol, Assistant Professor Cardiology, BSMU. Dr. S. Habibullah Selim, Assistant Professor Cardiology, Sylhet M.A.G. Osmani Medical College. Dr. A.K. Manor Islam, Assistant Professor Cardiology, NICBD. And Dr. Salahuddin Ulubbi, ex-Associate Professor Cardiology, NICBD. And Dr. Ziyad Khan, Professor of Cardiology, Ibn Sina Medical College Hospital. Me, Dr. Govinda Pal, Assistant Professor Cardiology, Mansingh Medical College, moderator, and co-moderator Dr. Masuma Jannat, Assistant Professor from Ibrahim Cardiac Hospital and Research Institute. We have got 4 eminent speakers, and every speaker will get 20 minutes, except Shomir Shrivastava. He will get 25 minutes. After ending of this piece, question answer session and comments from panelists and also chairpersons. So may I request Dr. Debika Chatterjee, ma'am, from eminent speaker and cardiologist from Kolkata, chief of the non-invasive Rabindranath Tagore International Institute of Cardiac Science. Her topic, he talked about the role of 3D in echocardiography. Please, ma'am, share your screen.
Yeah, sure. Thank you, chairpersons and the moderators, and good afternoon, everybody. I'm going to speak about role of 3D echocardiography. Now, since the introduction of 3D echocardiography for the last 5 decades, various advancements have taken place in the field of its technology. We don't have to, spend our precious time for offline post-processing or cropping. We can see the cardiac structures in real time. And even if we need to do the cropping, we can do it very fast. Now, let us look at this illustration to understand the concept of 2D versus 3D echo. In 2D echo, the scan lines are emitted from the 2D transducer, and they remain side by side, forming a thin slice of imaging sector. On the contrary, in 3D echocardiography, back to back, there are a number of slices, as you can see, and the entire heart comes inside the full volume data set, from where we can take infinite cut planes, just like cardiac MRI. And after cropping, we can see direct on-first anatomical views of cardiac structures. Now, just like car driving, which has several different modes of driving, 3D echo also has different modes like real-time, full volume, zoomed mode. But each mode is a trade-off between sector width, frame rate, and spatial resolution. When we go for a real-time 3D imaging, it is having a very high frame rate, but a narrow sector width is seen. As you can see, it's useful for a very quick scanning of the heart to see the small structures. Image can be rotated in any direction, and it basically helps in positioning of the probe, adjustment of the sector, rotation, depth, etc. Whereas full volume acquisition mode is not a real-time imaging modality. Here we acquire multiple 3D sub-volumes over multiple bits. As in this case, we are acquiring over 4 bits. And these sub-volumes are stitched together by the machine, and they are synchronized, and they are stored as full volume data set, having a 90-degree lateral by 90-degree elevation plane at variable depth. So at the outset, when we acquire the full volume data set, we cannot see the intracardiac structures. We need to eliminate the data to visualize the region of interest, which again depends on the structure we need to assess. Like this is a 3D full volume data set. We need to eliminate the data to see our structure of interest. That elimination we do in 3 planes, X, Y, and Z. As in this case, to visualize the ostium secundum ASD, we have done the elimination of data. 3D zoomed mode acquisition is a very popular mode. It is basically a magnified 3D data set which is acquired over 1 bit, as you can see, and then it is cropped. So since it is acquired over 1 bit, it's very useful in arrhythmias or a noisy ECG. And if the patient cannot hold the breath during full volume acquisition, this is very, this shows advantage. But it has got a disadvantage of low frame rate and low spatial resolution, since it is acquired over 1 bit only. Now let us see some of the applications of 3D in echo imaging. Now, one such area where 3-dimensional echo has consistently been shown to have the superior accuracy over 2D is the assessment of LV volumes and ejection fraction, because this information is very much necessary to comment on the prognosis after MI, or to take decision on the medication or device therapy. We do in the assessment of the LV volume and ejection fraction in 2D echocardiography by using biplane disk summation method, where we manually trace the endocardial margin of LV in end diastole and end systole of 4-chamber and 2-chamber to get the ejection fraction and the volume, end systolic and end diastolic volume. Well, this method has got various pitfalls, like foreshortening is a problem. Often we get suboptimal endocardial definition where tracing is a problem. And since we see only 2 cross-sectional views of LV, so basically we are getting partial information. And to some extent, the machine does geometric assumption also. So all these factors lead to high intra and inter-observer variability, resulting in underestimation of volume and ejection fraction relative to MRI. On the other hand, if we look at the 3D quantification of the LV volume and ejection fraction, it shows much superior accuracy and reproducibility over 2D imaging, because 3D echo is intrinsically volumetric. It doesn't rely on the geometric assumption. So as a result of which it results in very low intra and inter-observer variability. So better correlation with the CMR. And that is why it is recommended in all the labs with experience in 3-dimensional echocardiography. Not only the LV, the 3D echocardiography has shown its supremacy for the measurement of RV volume and ejection fraction also. And we know how difficult it is to measure the RV volume and ejection fraction. We cannot do by 2D echocardiography because RVs, for RV, the inflow and the outflow lies in 2 different planes. Whereas in 3D, we can easily acquire the multi-bit 3D data set to generate the 3D model to give us the end-systolic volume, end-diastolic volume, the stroke volume, ejection fraction of RV. So we get the full data set of RV, including the ejection fraction. Though it has got a limitation that we need a specific software, it depends on the image quality, and the reference values are not yet established. Another area where 3D imaging has shown its supremacy is the 3D imaging of heart valves, where we get a realistic views by 3D echo. Because heart valves are inherently 3-dimensional in structure. So when we do the 2-dimensional echocardiography, to assess the pathology of mitral valve, we need multiple views, even with transesophageal echo. At least 5 views to comment on all the scallops of the mitral valve. Whereas in 3-dimensional echocardiography, we can see the entire mitral valve in a single screen display. So it is a realistic representation and becomes a common language between the imaging cardiologist and the surgeon or the interventionist. Look at this view. This is a surgeon's view from left atrium to the mitral valve. Just like the model, you will see the aorta is at 12 o'clock position, AML at the top, PML at the bottom, L appendage on the surgeon's left side. So it's exactly the realistic representation of surgeon's view. And that is why 3D imaging of the mitral valve can identify the leaflets, scallops, commissures very accurately, including the cleft, perforation, prolapse of the leaflets, and also the identification of the attachment of vegetations. Let us have a look at this patient, who is 45 years old female, presented with shortness of breath in class 3. On auscultation, we got hollow systolic murmur. Now, as I did the 2-dimensional transesophageal echocardiography, I could see that there is a significant mitral agitation and prolapse of some scallop in the mid-esophageal 4-chamber view at 0 degree, but I couldn't identify which scallop it is. Even at the commissural view or in the long axis view, I could say that either it is P2 or P3. I was not very accurate about the exact scallop of the PML. But as I did the 3-dimensional echo, you can see here, look at the PML. This is the P1, P2, absolutely fine. It is the P3 scallop only, which is showing a caudal rupture leading to prolapse of the P3 scallop. So this information is very much necessary for feasibility and success for mitral valve repair, because success depends on the accurate identification of the anatomical lesion. Another patient, a young male, presented with sudden shortness of breath, who had a blunt chest trauma. On auscultation, again, we got holosystolic murmur radiating to axilla. And in two-dimensional echo with severe MR, and look at the PML, it's looking flail. And we know the causes of MR in blunt chest trauma is either rupture of AML or CODI or papillary muscle. Now, I was not very sure about the caudal rupture, only I could see that PML is flail. But as I did the three-dimensional echocardiography, I could see there are multiple caudae which are ruptured, as you can see here, attached to the PML. So basically, the caudal rupture, multiple caudal rupture has resulted in severe MR in this case. Another area where 3D echo has shown a revolution in cardiovascular imaging is the assessment of atrial septal defect, because atrial septum is a complex three-dimensional structure. So whenever we see I see an ASD in two-dimensional echocardiography, we always try to mentally recreate the 3D image of that 2D image, just like we do the three-dimensional imaging of a globe from a 2D flat map of the Earth, which is so much inaccurate if we think about the globe from this picture only. So it is not very accurate always. Whereas in case of three-dimensional echo, we can rapidly and accurately assess the atrial septal defect regarding its position, orientation, and spatial relationship to the surrounding structures. As you can see, here is the SVC entering into the array, and here is the IVC, aorta, and this is the tricuspid valve. So we can see exactly where the ASD is located. And not only that, we can also comment on the number of ASDs. Like here, it's a single ASD. We can assess the size of the ASD, and also very important is the measurement of size of rims of the ASD, because the device closure can be done if the rims are adequate in size. These are the rims. This is SBC rim, IVC rim, and this is the aortic rim, atrioventricular rim, and the posterior rim. All the rims are adequate in this ASD, so ideal for device closure. And look at this patient. I did two-dimensional transesophageal echo. What I could see that there is a deficient aortic rim. All other rims looked adequate other than floppy IVC rim. But I had a doubt about the number of ASDs. I could see a dropout here, but I couldn't see the flow properly other than a single ostium secundum ASD. But as I did the three-dimensional transesophageal echo, I could see the second ASD very well. So it is basically a fenestrated ostium secundum ASD. So it changes the line of treatment. It changes the decision for device closure, the size of the device, number of the device, everything. And another area where again 3D has got a very great role is the prosthetic valve. As you can see, as it provides the surgeon's view, so it's possible to see the prosthetic valve in its entirety. Like you see, this is the surgeon's view, so we can see the mitral valve from the LA perspective. This is the sewing ring, a bileaflet prosthetic valve showing all three orifices, small central orifice, and on either side there are good size orifices, all are opening well. Whereas look at this prosthesis, and the one disc is showing excursion, and one orifice is seen and other two are not seen. So basically this is a situation which is called stuck valve. And not only that, 3D echo has got a great role when there is a paravalvular leak in a prosthetic valve, and we think about the transcatheter device closure of that paravalvular leak, which is done entirely under transesophageal echo guidance. So this is a patient who is 35 years female, had MBR with bileaflet prosthesis a year back, presented with class 3-4 SOV for 7 days, but no history of fever. In transthoracic, we got this paravalvular leak, as you can see. And in transesophageal, we confirmed that there is a paravalvular leak, a echo dropout outside the sewing ring with MR in the color flow. So that confirms the diagnosis of paravalvular leak. So when we do the 2D echo, we confirm the diagnosis of paravalvular leak. We look at the excursion of the disc. We exclude the thrombus in the lap appendage. Also, we can quantify the MR from the paravalvular leak. But a very important decision regarding the choosing of the correct device is sizing of the PVL, or the paravalvular leak. Yes, we can measure the size. Here it measured around 3.8 millimeter, but we must realize that this is a two-dimensional measurement, and this measurement will be true size only if the paravalvular leak is cylindrical in shape. But paravalvular leaks are often crescent-shaped or they are serpiginous. So there comes the role of three-dimensional echocardiography, which is a preferred imaging modality to know the morphology of the paravalvular leak, because it allows better definition of the size and shape of the paravalvular leak. As you see here, this is a bileflate mitral prosthetic valve showing the sewing ring and the stitches on it. Both the discs are opening, but look at the paravalvular leak. It's here, and it is not at all cylindrical in shape. It's crescent shaped, and which is very, very crucial for choosing the correct device. And also size of the defect is about 1 centimeter by 0.4 centimeter. And not only that, with the help of three-dimensional echocardiography, localization of the leak also becomes easier. We can comment on the relation of the defect with the surrounding structure by providing the en-face view of the mitral prosthesis and by rotating it, and so that aorta comes at 12 o'clock position. If you think the mitral valve like a clock, so this paravalvular leak is at around 11 o'clock position. So that is a vital information to the interventionist to proceed with the wear and the delivery system, and that ensures the adequate positioning of the device, and the interventionist can deploy the device without any residual leak. So there is a great role of 3D echo in prosthetic valve. And also a great role played during mitral clipping. For each and every step of mitral clipping is done by three-dimensional transesophageal echocardiography, starting from advancement of the clip delivery system to as the mitral valve, positioning of the mitral clip above the mitral leaflets, grasping the leaflets, and evaluating the adequate leaflet insertion, clip release, everything. So, looking at the various, the great impact of 3D echo on diagnosis and management of the patient, now a time has come to think whether we can replace the 2D echo by 3D echo. Well, we must realize that there are various challenges still persisting in 3D echocardiography. Many of us are not well versed with the 3D echo. We are in our learning curve, which cannot be rushed. And 3D echo is not always as good as it sounds, because 3D image quality depends a lot on the 2D image quality. If the 2D image is suboptimal, it will result in suboptimal 3D image. And also image quality is a trade-off between the sector width, frame rate, and spatial resolution, as we have already seen. And stitching artifact in multi-bit full volume acquisition is a real problem, which are the demarcation lines between the sub-volumes, and distort the anatomical structure. It's because of the arrhythmia, probe movement, or if the patient cannot hold the breath properly. And also the color Doppler acquisition in 3D is limited to the small volume with limited temporal resolution. So until the challenges are solved, we need to use the 3D to complement the 2D echo. 3D echo cannot replace the 2D echo, but looking at the advancement of the science and technology, we can assume that all these challenges will be solved very soon. By that time, if we can develop our expertise, we will be able to do the 3D echo properly. So all echo labs should have at least one 3D echo system to develop the expertise. Thank you.
Thank you, ma'am, for your brilliant talk. Undoubtedly, very much informative. Actually, echo, it's a multifaceted and multidimensional and played tremendous role like 3D, 4D for the diagnosis of different form of cardiac disease in the field of cardiology. Now, our next speaker, honorable speaker, Dr. Avhijit Chatterjee, consultant Narayana Health and Kolkata Rabindranath Tagore International Institute of Cardiac Science. Field of expertise, intervention cardiology and echocardiography as well. Sir, Dr. Avhijit Chatterjee, please share your screen. He is present or not?
Yes, I am present.
Okay, sir. Thank you, sir. Most welcome. Good afternoon.
Good afternoon. Yes. I really belong to Chittagong now, although I am originally from R.N. Tagore Hospital. I am posted in Imperial Hospital, Chittagong. Can you see my slide?
No.
Yet now. It's not.
Can you see it now?
No, sir.
Okay. Is that better?
No, sir.
Oh God. Don't worry. Then what do I do? What do I do next?
We are always
No
with
problem.
you.
It will solve. Don't hurry. It will solve.
Yeah, please tell me what to do.
Technical personnel from Beximco.
Please open your slides in the desktop and
yes,
then go to the share screen.
Share.
I think, yeah. Open your, it's coming.
Starting, yes.
Can you see now?
Okay.
Yes, sir.
So my old friends in Bangladesh, I'll be going back to Chittagong in about a week or two, and I'll be there working with you. So here I am to talk about the pericardium.
Presentation mode, sir, please.
Presentation mode, yes, I'll do that. So I'm going to talk on pericardial disease. A quick word about the anatomy. The pericardium consists of an outer sac of fibrous pericardium and an inner sac which is double layered. This is serous pericardium. Pericardial fluid resides within the visceral and parietal layers of the serous pericardium. What is the function of the pericardium? It gives mechanical protection to the heart. It provides lubrication, prevents acute distension of the heart, and provides diastolic coupling of the two ventricles. That is, when one ventricle overfills, the other underfills, and vice versa. How do you assess the pericardial thickness echocardiographically? We increase the damping of the 2D picture to a point that the myocardium is no longer visible. The M mode beam will now visualize the relatively dense pericardial echoes. It is a relatively crude method. Better methods are done with other forms of imaging technology, for example, CT scanning and MRI scanning, which we are not going to discuss here. Here I have purposely changed the gain setting so that only the posterior pericardium is available and I can measure the thickness. Same thing on M mode. Pericardial effusion is said to occur when a significant amount of fluid resides within the pericardium. Less than 25 ml fluid, echo-free space posterior to the left ventricle that is visible in diastole but disappears in systole. Greater than 25 milliliter fluid, echo-free space posterior to LV that is visible throughout the cardiac cycle. We must be careful not to label an echo-free space that is seen only anteriorly as pericardial effusion. It may be caused by mediastinal fat, fibrosis, thymus, or other tissue. How do we assess the severity of the pericardial effusion? A small effusion is said to occur when there is less than 1 centimeter of posterior echo-free space with or without a fluid accumulation elsewhere. Moderate, 1 to 2 centimeter, and large is more than 2 centimeter. Definitions vary from lab to lab. Accurate quantification of pericardial fluid can be done with 3D echo. Here you can see a small chink of fluid posterior to the left ventricle. This is physiological. Here also, a very small chink, insignificant. Now, the million-dollar question, fluid behind the heart, is it pleural or pericardial? Pericardial fluid lies in front of the descending thoracic aorta. Pleural fluid extends behind the descending thoracic aorta. Now here you can see the descending thoracic aorta as the circle behind the left atrium, and this fluid lies anterior. If it lies posterior, then this is pleural effusion. Let's have a quick word on pericardial tamponade. Normal pericardial pressure 2 to 4 millimeters mercury. Slow accumulation of fluid is hemodynamically well tolerated because of gradual stretching of the fibrous pericardium. Quick accumulation of fluid raises the pericardial pressure acutely because the fibrous pericardium cannot be stretched so quickly. This results in cardiac tamponade. If the pericardial pressure is less than 10 millimeters mercury, we call it mild tamponade. If more than 10, it is severe. Tamponade primarily affects the right side of the heart because the RV free wall is thinner than the left LV free wall and is easier to be compressed, and left-sided pressures are higher than the right-sided pressures and resist compression for a longer period of time. This is the principle of continuity. What goes in is equal to what comes out. Underfilling of the RA and RV in turn causes underfilling of the LA and LV. This results in reduced cardiac output, low blood pressure, compensatory tachycardia, and finally shock. Can you see the collapse of the RA? The RA is a thin-walled structure, and this is diastolic collapse. This is RV free wall collapse. This is a more specific indicator of pericardial tamponade. Look at the collapse over here. Free wall of the RV. The right ventricular outflow tract is collapsing. This is the pericardial fluid, and this is the RV free wall. This is a swinging heart, which is found in large pericardial effusions. This is the collapse of the RV wall in diastole. This is the collapse of the RVOT collapse in diastole here. If you put a pulse wave Doppler across the mitral valve, you find respiratory variation of the amplitude of the E and A waves. The flow decreases during expiration and increases during inspiration. The expected difference between the maximum and minimum E wave amplitudes is more than 25%. Tricuspid valve, basically the same type of variation. The flow increases during inspiration and decreases during expiration. That is exactly opposite to what happens to the mitral flow. Constrictive pericarditis. Here is a postmortem specimen showing thickened pericardium. A part of it has been stripped to allow visualization of the epicardial surface of the heart, and this shows the reciprocal changes in the right ventricular and right atrial dimensions, and also the Doppler flows in the various cardiac chambers and vessels. The thick scarred pericardium of constrictive pericarditis restricts the relaxation of the heart in diastole. There is a restrictive filling defect. There is elevation and equalization of the filling pressures in all the 4 cardiac chambers, systemic and pulmonary veins. In early diastole, the ventricles fill abnormally rapidly because of increased atrial pressures and increased ventricular suction. During early to mid diastole, the ventricular filling ceases rapidly when the intracardiac volume reaches the limit set by the stiff pericardium. As a result, almost all the filling occurs early in diastole. The reduced cardiac output is a consequence of impaired ventricular filling. In pure constriction, contractile function is preserved, although the ejection fraction can be low because of decreased preload. The myocardium is often involved by the chronic inflammation and fibrosis. This results in true contractile dysfunction, and the results of pericardiectomy are poor. What are the 2D findings? There is hyper-reflective pericardium, may not always be present, and there is something which is known as septal bounce. Here you see jerky motion of the septum. This is a typical finding in constrictive pericarditis. There is jerky movement of the septum. Again, jerky movement of the septum. Hyper-reflective pericardium over here. Septal bounce once again, short axis view. There is no mitral regurgitation. This is in sharp contrast to the findings in restrictive cardiomyopathy. Look at the tricuspid valve. No tricuspid regurgitation, in contrast with restrictive cardiomyopathy. The IVC is dilated and there are no changes of caliber with respiration. Septal bounce, flattening of the posterior wall motion, and pulsus paradoxus. M-mode study of the pulmonary valve, steep early part because of the premature opening of the pulmonary valve by the elevated RV pressure. PW Doppler of the mitral valve shows more than 25% variation in the E wave amplitude, and between inspiration and expiration is diagnostic. The pulse wave Doppler of the tricuspid valve shows respiratory variation. Now this is interesting. This is the tissue Doppler of the medial mitral annulus. There is a supranormal of E prime. See, normally it is about 7 or 10, and here it is about 16. Annulus reversus mitral septal annulus TDI is more than the lateral annulus TDI. Now, the million-dollar question is, am I dealing with constrictive pericarditis or restrictive cardiomyopathy? On inspection of the two-dimensional pictures in a patient of restrictive cardiomyopathy, we see biatrial enlargement, good biventricular systolic function, at least in the initial stages, and a restrictive filling pattern. This is a patient of restrictive cardiomyopathy. Severe mitral regurgitation. Severe tricuspid regurgitation. And you see that the deceleration time is barely 128 milliseconds. So this shows a bad prognosis, restrictive flow pattern. And there is pulmonary arterial hypertension in endomyocardial fibrosis. Here it is about how much? 58. To that, you add the right atrial pressure, it becomes something like 70 millimeters mercury. The IVC is dilated and there is hardly any change with respiration. So what are the differences in echo and Doppler between constriction and restriction? The respiratory variation in left to right atrial flow is exaggerated in constriction. It is normal in restriction. The ventricular wall thickness is usually increased in restriction. It is normal in constriction. Atrial size cannot distinguish septal bounce is present in constriction, and the tissue Doppler E wave velocity is increased in constriction but reduced in restriction. Speckle tracking shows normal longitudinal and reduced circumferential strain. The opposite is seen in restriction, and pericardial thickness in constrictive pericarditis is increased, whereas it is normal with restriction. Here is an interesting thing known as effusive constrictive pericarditis. It shows features of effusion or tamponade along with constriction. It usually has an initial subacute course. And inflammatory effusion may dominate the picture early with constrictive findings later on. The etiology can be tuberculosis, idiopathic, malignancy, and after radiation for cancer therapy. The failure of right atrial pressure to decline by at least 50% to a level below 10 millimeters mercury when the pericardial pressure is reduced to nearly 0 millimeters mercury by pericardiocentesis. This is a patient who has got effusive constrictive pericarditis. There are multiple strands and loculi in the pericardial space. So, thank you. Thanks very much.
Dr. Gobindo, can you invite the next speaker?
Sir?
Okay. Masumazanat, you may proceed.
Yes, that was a brilliant presentation and very informative. Thank you so much, sir, for your time. Now our next speaker is very experienced and very close and very loyal to us, Dr. Shrivastava, Director of and Head of Non-Invasive Cardiology for his HASCOT Heart Institute, New Delhi. Sir, you will be presenting his speech on echocardiographic overview of cardiomyopathy. Please, sir, you may share your screen. Dr. Shrivastava. Sir, are you hearing, sir?
He is not available now.
Okay, may I call the next speaker, sir? May I call next speaker, sir?
Dr. Samir is not available, then you can switch over to next speaker.
Next speaker of the session is very talented and very close, Dr. Rakesh Gupta, Consultant Cardiology, Chairpersons Healthcare, Delhi, India. He will be presenting his speech on basic and beyond in transesophageal echocardiography. What guidelines say? Sir, please, you may share your screen. Dr. Rakesh Gupta.
Shumir is not available.
No, sir.
No, thank you. Okay. Go on, Dr. Rakesh.
Rakesh Gupta, sir, is no. I think he is not also available.
So what can we do?
What to do, Sajal? I think can we go to the next program, and before that you can discuss the presentations, and if
sir, we can discuss the two presentation.
Close the session, sir.
Question answer session. So, any comments from panelists or chairpersons? Any comments or opinion regarding each? Professor M. Shahabuddin, sir, any comments?
Yes. Thank you, Dr. Gobindo Kanti, for asking me for any comments. I was listening very attentively. Both the speakers speaks very vividly and very exclusively and very nicely. Ma'am, Debika Chatterjee ma'am has explained the 3D echocardiogram. I think that the 3D echocardiogram is now will be the routine procedures. But lastly, ma'am said it's complementary, not it will replace the 2D echocardiogram. There is an excellent view in 3D echocardiogram that we can definitely we can recognize the valve structures as well as the congenital defects also. So, ma'am, it's a very excellent presentation regarding your part. And Dr. Avhijit Chatterjee, you are very much excellent in your presentation. You have nicely presented in very short way the basic and the beyond pericardial and myocardial disease. Thank you very much. I have no query, no argument. I have learned a lot from both of them. Thank you, sir.
Any comments from Dr. A.B.M. Salam sir, Professor A.B.M. Salam sir? If any comments?
Dr. Govindo and the organizer, particularly Professor Nazir Islam sir, and Professor for inviting me being as a panelist of this important session where the
Sir,
delivering particularly am I audible?
Yes, sir. Yes, sir.
Yes.
Debika Chatterjee is always wonderful. I enjoyed his lecture previously, and today he vividly described. It was very illustrative and informative how 3D echo is playing a role for diagnosing as well as for intervention. Particularly, I being the pediatric cardiologist, we frequently use this 3D echo for particularly for this ASD device user. I usually especially do a maneuver which is known as a rat lead. I was asking for her to say in detail before they begin how they can do and cropping the 3D.
It's a lateral 90.
Very nicely showed case examples. So it was wonderful to hear from her again, as like as before. I like to congratulate and thanks to her. And second speaker, Dr. Avhijit Chatterjee, he also nicely described the pathogenesis of pericardial disease. And,
excuse me, sir. Our Shrivastava and also Rakesh Gupta sir joining with us just now.
Later on.
Okay. Comments later on. Now I'd like to request Shrivastava, Dr. Shrivastava, please. Director and head of the department non-invasive cardiology and head of the research department of Fortis Escort Heart Institute, New Delhi, and past president of Indian Academy of Echocardiography and editorial board member of Indian Heart Journal and Journal of Indian Academy of Echocardiography. And his special interest in transesophageal echo, stress echo, and vascular Doppler. Now talk on echocardiographic overview of cardiomyopathy. 25 minutes. Sir, please, sir, share your screen.
Allow me to share my screen, please.
Yes, sir.
Sir, you
Welcome,
can share your screen.
Thank you for the kind invite, sir. And Dada Kamal.
Fine.
I'm just trying to get into my... So, good afternoon to you all and a warm welcome for myself into Dhaka. I never miss a chance to be in Dhaka for two reasons. One is hospitality of people and second is hilsha cooked in mustard oil. So my 25 minutes will start now. Overview of cardiomyopathy. We know that there are three types of cardiomyopathies: restrictive, hypertrophic, and dilated. Each type of this cardiomyopathy is a book in itself. and people have spent their lifetimes in subsets of these books and chapters. I can finish my talk here with this slide, but I would prefer to start my talk from here. So there are, this cartoon is sum and substance of what I'm going to talk. This is on the top left is normal, on the top right is dilated cardiomyopathy, where the ventricles are dilated and they are poorly functional. This on the left is hypertrophic cardiomyopathy, which means the walls of the ventricles are thickened but have become stiffened. And this fourth variety is restrictive cardiomyopathy. The walls of the ventricles become stiff, but they may not necessarily be thickened. Now, I'll start with the hypertrophic cardiomyopathy and the mimickers. So here is an example of hypertrophic cardiomyopathy where there is a premature closure in M mode. And when M mode was the only modality of diagnosis in echocardiography, this used to be the sine qua non, premature closure. That means there is an obstruction in the LVOT, which once the gradients fall, opens up again. And this is a dip, which you see in the conventional box type. If you see that there is a premature closure of aortic valve, start thinking in terms of LVOT obstruction. And any LVOT obstruction on those days was taken to be hypertrophic obstructive cardiomyopathy. Now, not only that, you can see a classical kind of dagger shape of Doppler parameters. And when you look at hypertrophic cardiomyopathy in its true sense in the conventional 2D or M mode in 2D, you find that here it is that there is a thickened cardiomyopathy, interventricular septum. It is asymmetrical. The thickness of the septum is far larger than the posterior wall. Now you don't call it posterior wall, you call it inferior lateral wall. And here, when you look at it, you will find that there is a asymmetrical septal hypertrophy too. Now, there are several types of hypertrophy. We are just going to skip through most of them, but to complete that not all hypertrophies are hypertrophic obstructive cardiomyopathy, or not all hypertrophies are hypertrophic cardiomyopathy. Again, the most classical example we see is in hypertension. And when you see it in hypertension, you don't find the characteristic changes as you would expect in some infiltrative disorders, and the myocardium is not very classical. It is the usual myocardium. And here it is that you'll find that many a times with hypertrophy of any variety, you can get an LVOT obstruction. Here there is some gradient and turbulence across the LVOT, as you can see in the color Doppler, but this is not classical hypertrophic obstructive cardiomyopathy because you have to have these things in absence of hypertension. Here is yet another way in which you can find hypertrophs. This is a very densely calcific aortic valve, and when you see the Dopplers across this, you'll find that there is a aortic regurgitation, no doubt about it, but the Doppler patterns are quite classical for severe aortic stenosis, and this is what it is. So there is some bit of an AR also, but by the Doppler tracings, the AR doesn't seem to be too severe. Actually, longer the pressure half time in aortic regurgitation, lesser is the severity of aortic regurgitation. Now, this is a place where on the left, if you closely look at the tip of the mitral, you'll find that in systole, there is a systolic anterior motion. This goes towards the septum. And here, when you see the short axis, you'll find that there is classical hypertrophy, which is there, and it is quite concentric in nature rather than asymmetrical septal hypertrophy. It's not that you will have only asymmetrical septal hypertrophy, but if you get a concentric hypertrophy, start thinking in terms of several other things other than hypertrophic cardiomyopathy as a possibility. Now, this is what we find. And if you look at it, infiltrative disorders will have this central corridor sign. This is a very important sign to see. If an amyloid is there, the central hypertrophic cardiomyopathy, this is an infiltrative disorder, and that's the reason why you must think in terms of something else other than hypertrophic cardiomyopathy. And this is classical amyloid as what is expected in several features. It has a sparkling feature. If you look at the myocardium, it has a characteristic sparkling feature. And when you do a strain, then the bullseye will have an apical sparing. Though apical sparing is not necessarily definitively because of amyloid, neither is it a definitive thing against amyloid. But once you start seeing a cherry on top kind of a feature, then amyloid becomes high on the probability. Now, this was proven by biopsy. We took it from the myocardium. Now, this is another. So most people would say this is amyloid. But amyloid, if you look at this in different views, you'll find that there are certain serrations, there are recesses. Amyloid is solid, should be solid. I mean, not necessarily so. And this is the reason why we started investigating this further. Because classically speaking, if you make a diagnosis of amyloid, there are treatments available for it now, at least in 2020 onwards. But here, if you look at this, this was not classical amyloid, because if you see amyloid, you should not see these recesses, and somehow the things were not gelling. And when we started digging at it too much, then we found that yes, we got an MRI done, which was kind of non-contributory, and we went ahead with a biopsy. And once we got the biopsy done, we found, he had a mitral regurgitation too. So this again is a restrictive cardiomyopathy kind of situation. And our diagnosis turned out to be infiltrative disorder, which was Fabry's disease. So not all restrictive disorders will be amyloid, not all restrictive disorders. So one more example of RCMP, which is very peculiar to this part of the world. Now, if you look at this, you'll find that the apices are obliterated. The left ventricular apices apex is obliterated. So we find this in eosinophilic hyper eosinophilic syndromes, but here the eosinophil counts were normal, and then we found that this turned out to be nothing but endomyocardial fibrosis, which is quite peculiar to south of India, as we see. So how do you make a diagnosis or a suspicion of restrictive cardiomyopathy? The first suspicion of restrictive cardiomyopathy is if you have biatrial enlargement with small ventricles. If you have biatrial enlargement with small ventricles, rest assured what you are dealing with is probably a restrictive cardiomyopathy situation. Just to complete the restriction versus constriction, this is always a fight. And if you look at the Doppler parameters, it will all be same. But if you have a restrictive cardiomyopathy, you will not get a septal bounce. Actually, septal bounce, if it is seen in only 2-3 conditions. One is in interventricular conduction defect, left bundle branch block. Normal variation is yes, but if you have a suspicion of anything, restriction versus constriction, if you get a septal bounce, 91% of the times it will be constrictive pericarditis. Now, this is a very classical constrictive pericarditis. And if you look at this, there are classical inspiratory, the moment there is an inspiration, you'll find that the septum bounces backwards and it pushes into this is a very, very gross example, not that you'll find it very often, but once you know the gross examples, you'll be able to see subtle things in future. Now, again, the Doppler velocities are quite classical. If you see a drop of Doppler gradients by 25% on the left side and more than 40% on the right side, they are quite classical for constrictive pericarditis. Not only that, you have to document RA pressures being high, which is very easily done by seeing dilated IVC. Now, these are few differences between restriction and constriction. If you see a pericardium which has got a calcium, favors constriction. If the LV size is normal, it is constriction. However, if there is hypertrophied LV, then it favors restriction. Regional wall motion abnormality may be seen in restriction. Echogenicity is characteristic few in restrictive cardiomyopathy, like in amyloid. Endomyocardium may be thickened. Global LV functions are by and large normal in constriction, but in restriction they may be impaired. Atrial size is by and large. Biatrial enlargement is a feature of restrictive cardiomyopathy. LV filling absent respiratory variations is seen in restriction. However, if there is a fall in inspiration, it favors constriction. Fall of inspiration and during inspiration, if there is an increase in right-sided valves like tricuspid, it favors constriction. Now, what is important is the lateral versus medial tissue Doppler. Now, what happens in constrictive pericarditis is that when the heart is relaxing, it relaxes, and then there is a sudden caging. This sudden caging occurs because of a thickened pericardium. So when it relaxes, there is a sudden caging. So where is the caging? Anteriorly, there is pericardium, it cages. Laterally, there is pericardium, it cages. Inferiorly, there is a pericardium which cages. Posteriorly, there is pericardium which cages. The only place where it cannot cage the pericardium is the interventricular septum. So this interventricular septum starts bouncing. So you see a septal bounce. So there is a tissue Doppler. Normally what happens if you see the tissue Dopplers of medial versus lateral, you'll always find that the lateral tissue Doppler is lower than the medial. Lateral is more than the medial. But here what will happen is that because of the caging effect of the pericardium, the lateral tissue Dopplers are truncated and medial becomes higher. This is a reverse. This is a reverse phenomena, and this favors constriction. So this is easy way to find out restriction. You see, what happens in constriction is that the initial phase of diastole is unhampered. So the tissue velocities are fairly well preserved in constriction, except once there is a caging effect because of the pericardium. However, in restriction, the primary pathology is that of myocardium. And in myocardium, the problem of diastole is from the word go. So initial diastole is also involved as again constriction, where the initial diastole is not hampered. Now there is yet another cardiomyopathy where the heart is weak and the ventricles are also enlarged. This is classically dilated cardiomyopathy. The dilated cardiomyopathy by definition is a cardiomyopathy where there is global hypokinesia. And many a times you will find that this is more of a myth than reality, whereas global hypokinesia can be a part of ischemic cardiomyopathy, and regional wall motion abnormality is seen in large percentage of patients with dilated cardiomyopathy. And to sort out this issue, many a times you will need to use your other modalities like dobutamine stress echo to sort it out or make it surface. So these are the DCMP myths in reality. 40% of dilated cardiomyopathy have a wall motion abnormality, and not all cardiomyopathies are irreversible. We also feel that many a times that if you have dilated cardiomyopathy, it is irreversible. This is a phenomena which we have recently started resurfacing, though the autopsies have shown a spongy myocardium several centuries back. But here is an example where there is a non-compaction which will lead to a dilated cardiomyopathy. Not all will do that, but there is a small percentage of non-compacted LVs which eventually will land up with dilated cardiomyopathy-like situation. And this is how you diagnose. So if you look at the ECG on the left side, actually the ECG on the left side is LVH with strain. But when you look at the echo pictures, you find that the LV is poorly functional. Not only that, there is global hypokinesia too. And when you see it in other views, so this patient had a clot also at the apex, other than it having a spongy myocardium or a non-compacted LV. Now, this non-compacted LV is diagnostic in two ways. One is that you have to see the recesses in which you can see the entry of the blood, and for this you have to get the Nyquist limits down. And number two is you have to see the ratio of compacted versus non-compacted. Of course, if you see the tissue Dopplers are slow and low, and the pattern is kind of tall E, small a, and restrictive cardiomyopathy once it has reached that stage of advanced heart failure stage. So these are a few examples of non-compaction, which unfortunately has a variable. It's so unpredictable that you can't really say that which non-compacted LVs will end up with severe heart failure and which are the ones which will not. But here are a few examples that you would be able to see very gross findings. And the LV non-compaction occurs more often than not on the lateral side first, then rest of the places. So the diagnostic suggestions for non-compaction of LV is, first and foremost, is if there is a ECG and echo dichotomy. ECG shows LVH, and this thing shows poor LV. This is as against amyloid. In amyloid, the ventricles will be hypertrophied, but the ECG will show small. So this is a dichotomy in which you can settle the issue several times. So more than 3 recesses, and to make the blood flow into the recesses, you come down on your Nyquist limits to maybe 27 or 25, and non-compacted to compacted myocardium ratio should be more than 2:1. Yet another cardiomyopathy, again, not a very recent discovery, but it was the first paper was published in 1990, where in Japan they found there were 5 patients who came out with something known as a stress cardiomyopathy. And how do you make a diagnosis of stress cardiomyopathy is that the wall motion, apex starts ballooning, and the bases, they are hypercontractile. Now this hypercontractile LV and the basis is a typical feature of catecholamine-induced stress cardiomyopathy. Happens 9:1 time compared to men. Women are more prone to it. That's the precipitating factors could be physical stress like sepsis, surgery, parturition, and non-physical could be emotional upsurges. How do you make a diagnosis? You make a diagnosis of basal hypercontractility. If you look at this, this is a basal hypercontractile and the apex is balloon. Though more and more different types of Takasugos or stress-induced cardiomyopathy have been discovered, but the catch point is that you have to document normal coronaries. This is our one more example in pediatric of a dilated cardiomyopathy. 45 years old neonate diagnosed to have dilated cardiomyopathy, was admitted for intravenous immunoglobulin therapy, and on way had generalized convulsion. Now this was his ECG, by and large non-contributory, except that there were some QT interval which was prolonged. QT was rather markedly prolonged in this case, corrected for the age. I mean, if you look at the T waves are falling far beyond the middle of RR interval. So we know that QT interval is rather prolonged. Did the echo? Echo was global hypokinesia. So whenever you see a pediatric age group with global hypokinesia and poor LV, you start looking at Al-Kappa, you start looking at coarctation, you start looking at of the LVOT obstruction. We couldn't find any, and we just felt that we must. So the familial history was that mother was not on calcium or magnesium, and ALPs were very high. Rest of the things was fine, and he turned out to have a very low calcium. And to manage this baby, we gave him injectable vitamin D, calcium, and magnesium sulfate, along with decongestive therapy with digoxin, Lasix, and ACE inhibitors. So there is a fight. If the blood pressure is fairly good, you must give alpha and beta blockers also. But in case the blood pressure is low, then you have to play with inotropes. Now, soon after that, this was, when was this? This was June and August. This is his echo. And you'd find that because so soon after correction, the LV starts improving, and it starts improving in not weeks or months, it starts improving in days. And this is after 3 months where the LV was fairly good. So this is one feature where in a neonate or a pediatric population, never miss a hypocalcemia. I'm not going into the mode of action, but I'll leave you with this and leave things for discussion more than anything else, that calcium has a mode of action which is direct myocardial contraction, increased digoxin effect, increased natriuresis, and direct effect on vitamin D on myocardium. Now, yet another example of a macroglossia with shortness of breath. Now, if you look at this, this is a classical amyloid. Sparkling feature in the septum, per LV, and there is nothing that you would want to see more. Again, here also there is a central corridor sign. Again, because any infiltrative disorder, amyloidosis being one of them, is a classical example. I think I'm overshooting my time. I'll just stop here and I'll be happy to take any questions in case there are any.
Thank you, sir. Thank you for your brilliant and very informative presentation. Thank you so much for time. Now, we will have our last speaker of the session, a very talented and very close, Dr. Rakesh Gupta, consultant cardiology, Chairpersons Healthcare Private Limited, Delhi, India. He will be presenting his speech on basic and beyond transesophageal echocardiography, what guidelines say.
Please, Dr. Rakesh Gupta, sir.
Yeah, I'm going on right now. Thank you very much.
Good evening, sir.
Good evening.
Most welcome.
Thank you very much for inviting me to talk on this platform of Bangladesh Echo Society. And I'm thankful to all of you for letting me talk on this very important topic, transesophageal echocardiography, which has really changed the scenario both for diagnosis, therapeutics, as well as intervention today. Let's see what we have in our armamentarium. This is what transesophageal and transthoracic echocardiography differences. In transthoracic, we scan from anterior to the heart, and in transesophageal, we scan posterior to the heart. And that's what makes a difference, like structure which is posteriorly placed like LA appendage, LA, thoracic aorta, and many of them, they do an excellent job as far as visualization is concerned. I just want to spend a second naming those people who were really responsible for development of transesophageal echocardiography. It goes back to the history, very old one, almost 1987, when Hishanga and et al., a Japanese person, was responsible for developing a transesophageal probe. Subsequently, Jim Stewart, back in Rochester, Minnesota, I happened to work with him in 90s, an excellent guy who was master of pediatric as well as adult echocardiography. And subsequently, Jacques Soquet, who was a French physician, was responsible in total development of this transesophageal echocardiography from 2 to 3 dimensions. Here is a whole list. I'm not going to go into detail of it, but you can look. 1977 was the first it was developed, and 2007 when we had a transesophageal real time, what we call the 4 dimensions transesophageal echocardiography. This is what certain guidelines are published by American Society of Echocardiography. And sitting at this platform, I like to say we should have our own guidelines coming up from this continent. This is a transesophageal probe which is being used. A very small miniature probe has become available now. I still remember a time when we started doing a single plane transesophageal echocardiography in 90, and it was just a small transducer sitting in front of it. And we have to do all planes just by rotating or anti-flexion or retroflexion of the probe. Advantages: 2 to 3 millimeter from a heart, closer to posterior structure, far from surgical area, very good resolution images, and it, as I said a couple of minutes back, better visualization of posterior structures, and on top of that, very significant role today in intraoperative. Semi-invasive process, chances of oropharyngeal injuries, need special setup and instrumentation, preparation of equipment, and the preparation of a physician also, because he need to be oriented with these images. What are the indication in 2010? Cardiovascular structure not seen in transthoracic echocardiography, especially posterior. Decision based on imaging quality, thrombus or vegetation. Difficult to image in poor transthoracic images, aortic atheromas visualization, dissection of aorta, intraoperative monitoring, and I like to add